Good afternoon. Now, I've got a difficult job of speaking about breast conservation in triple negative breast cancer, which is something that is still frowned at by many people. And I'm going to try and speak about this. Usually my topics are surgical, on plastic surgery, reconstruction, etc. But this time I'm talking about something that is medical oncology related, even though it is partly surgical. So may I just ask the audience, how many of you are surgeons? Wow, a lot of you. Okay, great. And how many of the surgeons believe that breast conservation is risky in triple negative breast cancer? Oh, very good. Oh, so my job is relatively easier, I think. I'm going to tell you all that it is safe. But would you trust me if I just say that? You should. We practice evidence-based medicine. So I need to give you the evidence for whatever I say. Yeah? So I'll try to do that. Right, so we all know what is a triple negative cancer. So I don't have to waste too much time on this slide, but it is, even though it is not a common cancer, 10 to 50% are triple negative breast cancers. And in Indian subcontinent, there are, I don't think it's just 15%, it's much more than that. And it has got poor prognosis for various reasons. It is generally thought to be more aggressive. We heard Professor Ismail Jacobi this morning, and he did mention that as well. Early stage TNBC is more likely to present with distant metastasis as well. So at outset, we are looking at a very aggressive cancer, 5% present with deep no metastasis. And they have got more risk of local recurrence. And we can see from the CS stages what's the 5-year survival rate. Localized cancer has got the best. All stages combined is about 77%. But the patients presenting with distant metastasis, they've got a very, very, very poor survival rate. However, newer treatments, and we did hear about those newer treatments like PD-L1 inhibitors, olaparib, etc. They have given some hope to us, and we are seeing more improved overall survival and disease-free survival. Also, downstage the tumor, we can make a tumor that is inoperable operable by giving them neoadjuvant therapy. And we can also provide the patients with an option of having breast conserving surgery by doing the neoadjuvant chemotherapy. So we know what is the surgical management is. It's either BCS or mastectomy with axillary staging or axillary node clearance. We are not going to cover the surgical procedures here. What we are going to see is whether breast conservation is safe, as safe as mastectomy in triple negative breast cancers. So yeah, mastectomy versus breast cancer, breast conserving surgery. So I saw a few hands earlier that said that they will opt for mastectomy in any tumor, triple negative breast cancer. Is that right? Can I have a show of hands again, please? Who would want to do mastectomy in any triple negative breast cancer, even if it is, even if lumpectomy is possible? Anybody? Okay, that makes my job easier now. So let's see if we can present with some evidence. So this is the meta-analysis of the German press group, and they almost had over 1,600 patients. They were all T1, N0, or N0 after chemotherapy, after neoadjuvant chemotherapy. So their endpoints were local regional recurrence and disease-free survival, as well as overall survival. So this is how they recruited their patients, or rather trials. I'm sorry, this slide is not really clear, but it just shows the groups and their distribution. And there is a pattern of recurrence as well seen on that one. So they have seen the local regional recurrence rate, and perhaps is it clear to you guys? Okay, it's quite clear on those monitors. Okay. Yeah. Okay. So you can see that in BCS, actually, the 5-year survival rate is better. Why would that be? There is always a selection bias in these kind of cases. So you're not going to perform a PCS in a patient who has got probably most of the T3 tumors would have mastectomy. Most of the T4 tumors would have mastectomy even after NSCT. So there is a selection bias, but that bias is always going to remain. And that's the reason why we are seeing a better survival rate with BCS than mastectomy. However, as the bias is always going to remain, we should accept that and move on. So you can see that it was significantly better in patients who underwent BCS. And we can see that from these various analysis. So that was the conclusion of that trial. Have I been able to convince you that the BCS is safe in triple negative breast cancer? We are already convinced. So my job is now very easy. So just to drive that point home, I have got a couple of more meta-analysis. The first group had total of 2,600, just over 2,600 subjects. But this meta-analysis has got almost 20,000 subjects from various trials. And again, the results show that it was safe to do breast cancer surgery in triple negative breast cancer. Similarly, there was another group which had a meta-analysis where more than 100,000 patients were included. Okay, and that was from 18,997 publications. So there were all sorts of studies, RCTs, cohort studies, whatever. However, because of the large number of the studies chosen and large number of the patients, the subjects included, it becomes a very kind of compelling evidence. So these were the results of that meta-analysis, and I'm already convinced, and most of the audience is already convinced. So my job actually here is done. So it's a good thing that I don't have to talk too much here. We are already convinced that BCS is safe in triple negative breast cancer. So for those who are still not convinced, perhaps the lady over there who was not convinced, she is now convinced, looks like. But yes, I mean, there are other studies and you can actually go and visit, but I didn't want to include any individual studies. I have purposefully got these meta-analysis which would drive the point home that BCS is safe. There is still quite the patients still want mastectomy, especially when they are told that they are triple negative breast cancer. This is mainly in cost-popular cities. the patients are well educated, and they consult Dr. Google as well, and Dr. Google tells them to have mastectomy. So they come to you and say, "Oh, I have Googled and I should always have mastectomy." What would you say to them? We've got evidence. We've got evidence. We are not just plucking the things out of air and say that, "Oh, it's safe." That's why I said, if I told you that it's safe, you won't accept that. But I have given the evidence. So now it will be easy. So that's the way that the patient needs to be convinced as well. So it's no more. Or do we all agree on that? We all agree on that. Thank you. So I have used a few references. I'm keeping my talk to a very short duration because I don't need to convince you guys. You're already convinced. Thank you very much.
Dr. Amit, thanks for your nice presentation. I have a question that whether there was any difference between the size of the tumor at the primary diagnosis, whether for BCS, whether the size was small enough at the primary diagnosis, and if the size was very large in case of mastectomy. Is this primary diagnosis, the carcinoma tumor size was any factor for this fibrous survival?
That's a very good question. That's why I said earlier that bias is always going to be there, because you are not going to perform mastectomy for a very small tumor. You would consider BCS now that you are convinced. You will consider BCS for a small tumor. However, inflammatory breast cancers, all the patients with extensive skin involvement at presentation or chest involvement at presentation. So essentially, large tumors, T3 tumors, T4 tumors, a lot of T3 tumors would need eventual mastectomy, and most of T4 tumors would need eventual mastectomy even after NSCT. So that bias is always going to be there, and unfortunately we can't eliminate that, but fortunately we can just move on, because that's what we are going to do from now on.
Okay, thank you for the presentation. Do you consider the BCS even in the multicentric or multifocal CNC?
Okay, so with our oncologists at Tata, we are now, if there are two lesions in the breast, we are now doing two separate wide localizations and getting a boost to two separate areas. I haven't done it for 3 ER. However, 3 or more means that breast is unstable and they are more likely to have local recurrence. So, truly multicentric multifocal cancers, I still would go for breast cancer research.
You go for NSCT than for multicentric or
yes.
size is large. Even after you can offer the patients BCS
if the foci are concentrated in one area, then you can. However, if they are in 3 different places, 3 different quadrants, you can do separate wide localizations at 3 places. However,
if you go for surgery,
yeah,
and large area, say in upper quadrant, it is say 11, 10, 12, 3, 2 o'clock, then you can cover by separate incisions.
Absolutely. So if the cancer is at 11 o'clock, 2 o'clock and 6 o'clock, then it becomes difficult, isn't it? However, if they are all concentrated in one or even 2 quadrants, 2 adjacent quadrants, you can still do it. But you can even do therapeutic mammoplasty, vertical, whatever, horizontal, lateral. You can do a lot of things. However, if they are in remote areas, then
triple negative, we know, is a bad prognostic factor. So usually you try to do mastectomy. If you want to do breast colony surgery, any kind of relationship with K167?
Well, Ki-167 is always high in triple negative breast cancer in my experience, and I'm sure my esteemed colleagues on the dais would have some opinion on that as well. Ki67 is usually high
Usually high. Triple negative breast cancer Ki67 is usually high.
Yes.
So that condition, what will be?
It is a proliferating tumors.
Yes, that's right.
So that proliferating tumors
Index
always
is
have a
always
high
going to be
mutation,
high.
always case
Yes.
KX7 high.
Absolutely.
In triple negative, also in HER2 positive.
Absolutely, absolutely. So looking at Ki67 is not really going to be of any help to us in triple negative breast cancer, because triple negative breast cancer you are already thinking of chemotherapy, whether it is neoadjuvant chemotherapy or adjuvant chemotherapy. But ultimately it does not matter from surgical point of view, does it?
So triple negative breast cancer Ki67 high, also considered for breast conservative surgery. There is no difference mastectomy and conservative surgery.
No.
Outcome is same.
Yes, yes. But breast conserving surgery is always given with radiotherapy. Yeah.
Thank you so much. Our presenter is in shortage of time. His flight is waiting.
Thank you. I need to rush for the
I
flight.
must thank our presenter, Dr. Amar Deshpande, for such a nice presentation and nice conversation. Yes.
Thank you. Thank you.
And,
Unless I ask this, I think it should be complete. That's because he has got experience regarding BCP in PLBC. So, in over 2 years' time, do you face any problems? Is there any local recurrence or distal metastasis? And if so, then how should we manage those cases?
Okay. So local recurrence, if I find in 2 years' time, as Mr. said, then that has to be treated exactly as any recurrence. The biopsy, it gives us the features. We have to do metastatic workup to see if there is any metastasis from it. And then, after that, if they have already had lumpectomy and radiotherapy, then I worked in UK for 24 years before moving to Tata last year. And in the UK, the radiotherapy is not repeated. So if the radiotherapy is not going to be repeated, then we have to do completion mastectomy. Otherwise, there will be much higher local recurrence after first recurrence. So it has to be done, and also the medical oncologist would consider an alternative line of chemotherapy as well.
thank you, sir.
Thank you. Thank
We
you all.
will look forward